this week on the BackTable Podcast.
I tell people research is what keeps my heart pumping. It's just I love research, and it helps me understand what I do for my patients better and helps me become a better practitioner. It's the fun part of what I do, and this is just personally for me. It might be different for other people. If you tell me what is fun about what you do, I would tell you research is a big part of it. Being able to learn and show something and show new evidence. So for me, it's never work. It's a fun thing that I look at it.
Welcome to BackTable Podcast. I'm Tony Shanks, Vice Chair of Education in the OB Department at Indiana University School of Medicine, and it is my pleasure today to welcome Dr. Hiba Mustafa. She is a distinguished maternal-fetal medicine specialist and fetal interventionalist at Riley Children's Hospital. She currently has multiple hats, which we'll talk about today. She is the Director of Fetal Medicine and Surgery, the Director of the Placenta Accreta Spectrum Program, as well as the Director of the Ultrasound Elective. She's an internationally recognized expert in fetal diagnosis and therapy, and she has a very productive research track record, which we'll kind of share some highlights. It's my pleasure to welcome my colleague and friend, Dr. Hiba Mustafa. Welcome.
Hey, Tony. Thank you so much for hosting me today. It's an honor and pleasure. Thank you so much.
Yeah, so the reason why I thought you would be an excellent guest for this is because what you do kind of sits like on the cutting edge of technology. But I want to share a story for the audience that you are well aware of. I was at the hospital covering labor and delivery, and the hospital had just done a special on you, like a video documentary of one of the cases that you had done. And one of our medical students had seen that. And they saw you walking on labor and delivery, and it was like that student saw Taylor Swift. And she got so excited, and she said, "Was that Dr. Mustafa?" And I said, "Yes." And she was just so excited. So I had to introduce her. I know that students watch this and other people watch this. So I just wanted to share that with you. So thanks for coming.
Thank you so much. Yes, I remember that day, and you are so generous into bringing her and introducing her to me. I love medical students. They just can feel and see the energy and enthusiasm and willing to learn. So that was a big highlight for me.
So the reason why you were featured was because you're a fetal interventionalist. And for people that are watching this or listening to this, they may not know what that is. So can you tell us what a fetal interventionalist and maybe share like what that story was that they made the video of?
Yes. So the naming has been like variable across different institutions, but fetal interventionist or fetal surgeon or fetal therapist, some people would call it, is a person who finished certain type of training. And I'll talk about kind of the routes you can go to that training, but it focuses on pregnancies, high-risk pregnancies, in which they encounter certain complications during pregnancy related particularly to the fetus. So if the fetus have a certain condition, abnormality that affects either their survival or causes severe morbidity after birth, then the fetal interventionist or the therapist might be able to intervene in certain way, certain time of pregnancy if they are eligible, and most importantly, if benefits outweigh the risks, to either improve survival or hopefully reduce the morbidity of that condition.
Hiba, could you tell us about your training and when exactly you got interested in focusing on something that is so specialized?
Yeah, so I'm OBGYN, so OBGYN residency, then I did my maternal-fetal medicine fellowship. Maternal-fetal medicine, people know it as like high-risk OB specialists. So you focus whether it's mom or the baby have like some certain complications in pregnancy. And after the maternal-fetal medicine or MFM fellowship, I did the fetal surgery fellowship. So OBGYN residency is 4 years. MFM fellowship is 3 years, and then extra 2 years for fetal surgery fellowship. There's another route for it people might go, which is through the surgical route. So you do pediatric surgery, and then you do 2 years of fetal surgery fellowship. Might be a little bit different of what type of procedures you do, like how extensive, how big of a spectrum you can do if you go through the surgical route versus if you go through the MFM route kind of thing.
Well, with your own journey, when in residency did you decide MFM, and when within MFM did you decide fetal interventionalist versus just MFM?
No, actually, I think it started in residency. So I was a resident in New York, Mount Sinai, New York, and then there was a person who came from CHOP, and they did kind of like a lecture to the residents, and the lecture was about the twin transfusion syndrome. And they wanted basically if the patients that they did laser on and they ended up coming back to us, they wanted us to send the placentas back to them to do dye test. So basically, during this condition, there's like vascular connections between twins, and with the laser, you can burn these vascular connections. So they wanted to kind of look at the placentas after birth and inject dyes into those vessels just to see if they missed any vessels or how it's looking. So I was just a resident, very full of energy, full of hopes and dreams. And then this person comes and talks about something that to me personally appeared so fascinating and so intriguing. And so that's when I think I want to be a fetal surgeon. And I think why it was fascinating more to me that I wanted to take it as a career rather than other people. I was a person who was really into ultrasound. And this is kind of uncommon among OBGYN residents that they kind of allocate part of their residency time on ultrasound because, they're exhausted, they're doing so many rotations. I actually spent a lot of electives, a lot of my off time. If I have nothing to do, I'll go to the ultrasound unit. Something about ultrasound that always I loved to learn more about. And of any fetal interventionist, ultrasound is the biggest portion of their career kind of thing. So I think just my love to the ultrasound made this field just more fascinating to me. And I thought I can be like that person who was giving the lecture one day.
You know me, for the audience members, like I'm big into education, both medical student and residency. So people listening to this, they've done residency. They know that process of, applying it and matching. And then for those that specialize in, we know what that application process looks like in the training. So you did it continues to be specialized. How did you identify where to train, and what did the training actually look like after MFM fellowship?
Yes. For those people who are really into fetal intervention, it's definitely a good thing to do your MFM fellowship in a place that does offer that. However, after finishing my MFM fellowship, I did realize it's not necessarily true. And that's how many MFM fellows approach me, like when we go to SMFM or I go to any meeting. Those who are interested into the field, they come and they say, oh, I do my training in somewhere that they don't offer fetal intervention. And is that a disadvantage to me or not? I say absolutely not a disadvantage, because those places who are have a big program and they offer fellowships, etc., it's more focused on the team that does the fetal surgery. Usually they have a fetal intervention fellow who come to those cases, and the MFM fellow's involvement might not be as big, even if you get involved, because you're not planning to take this as a career. So they might not invest a lot of time, if that makes sense, rather than investing more time into their fetal intervention fellow. Yes, there is definitely advantage from seeing those cases, managing them pre-op, managing them post-op, but I don't want this to hinder MFM fellows from embarking on this step just because they did their fellowship somewhere that it does not do fetal intervention. Otherwise, I always say go do electives at those places and attend meetings and listen to lectures and read about these topics and learn the pathophysiology and the offerings and the techniques, etc. Because your main training gonna come during your fetal surgery fellowship. That's the time where people will be really focused on training you, letting you do it with your own hands and letting you scan and letting you make decisions. So yes, it's great if you do your MFM fellowship somewhere who offers it, but never feel disappointed if you match into a place that doesn't necessarily offer it. Because your main goal when you go to MFM fellowship is MFM. And that's why I always say, when you go to OBGYN residency, even if you like MIGS or gynec or whatever, focus on being an OBGYN resident. Learn the whole field, learn the whole spectrum, learn everything about L&D. Even if you don't like so much being on L&D. But eventually, when you become more of a senior resident, you can spend more electives and research on the place that you like to end up with. Similarly, for MFM fellowship, you entered MFM for an MFM. So learn the whole spectrum of MFM because you're going to manage those patients as a whole. I have a patient whom I'm managing her for fetal reasons, but I have to manage her diabetes and hypertension and everything else. Yeah, so basically, if you end up in a fellowship that does not offer it, don't feel disappointed. You're going to do still great. You're still going to end up matching hopefully into fetal surgery fellowships or find a place that's willing to train you and help you grow kind of thing.
What does the landscape look like? I'm familiar with how many maternal-fetal medicine fellowships there are in the country, but how many places actually, and you don't have to have a very specific number, but what does it look like? How many places both in the US and internationally are training people for this?
Very few. And people know this is not, or maybe they don't know, this is not an ACGME approved fellowship. So there's no certain guidelines or how should it look like. The way it looks like is per institution. The amount of years you do per institution, the cases that you do in your first year or second year, and how much research they require you to do is purely per institution. And even those institutions who offer the fellowship, generally they offer it for 2 years. Some of them decide to do, I'm not going to take another fellow until my fellow finishes the 2 years. Some of them, no, they would take a fellow every year. Some of them, they lose their funding because this is not like residency or MFM fellowship is not federally funded. So the institution or they have to find funds for that position. So they might lose funds over certain years, so they don't offer it. But generally, the people or the institutions who've been out there, it's Texas Children, Baylor in Texas, UT Houston, which is Memorial Children in Texas as well. Children's Hospital of Philadelphia, they have been on and off. This year they're taking a fellow, but they've been not taking for a few years, for example. And then you have Cincinnati Children, also kind of on and off. They took a fellow today who used to be my resident, but certain years they might not take. However, there are places who want to take a fellow, for example, to train and keep them as partners, for example. So I always say, don't feel like those places who offer fellowship would be your only options. Absolutely not. Go to the meetings, show yourself, show that you are a person who are interested into this field, and present yourself as a person who, if they're willing to take a fellow one day or help train someone to become their partner, you are available. So don't feel like those places and websites generally, for MFM fellowship, OBGYN residency, we go to Google, right? And we look on the websites. This is not something you necessarily will see on websites. This is more of a verbal communication. You know someone, you heard someone is offering a fellowship kind of thing. So always be there, present yourself, show your enthusiasm and interest, and people will reach out to you.
You mentioned ACGME, which kind of has oversight and accreditation, but in terms of informing what is taught at the residency level, we have things like CREOG and APCO that can provide information. At the fellowship level, we have the Society of Maternal-Fetal Medicine, SMFM. So what are the organizations that help inform what to teach in terms of what you have to learn as a fellow in fetal interventions?
There are no organizations, unfortunately. Yeah, I mean, there are educational resources. So SMFM has a few publications, for example, on maternal-fetal surgery, anesthesia, fetal anesthesia. They have some practice bulletins and opinions out there, but there are no organizations who kind of say you have to train for laser or an MC or fetal. So, for example, some people who offer this fellowship, they only do laser, FYI. So when you go somewhere and they offer you a position or a fellowship, you should ask, what am I being trained for? And many places would say we only do twin transfusion, for example. We don't do fetal, we don't do MMC. The thing with MMC and fetal, so MMC is myelomeningocele or spina bifida repair. Fetal is a procedure that is done for congenital diaphragmatic hernia, which is like a balloon tracheal occlusion. These two procedures, you require pediatric specialty support, right? You need a neurosurgery, you need a spina bifida clinic. For fetal, you need a place with very strong ECMO, with very strong pediatric surgery services. So if you don't have the pediatric specialty support, that's why many places don't do fetal, don't do MMC repair, while they do lasers, because for that one, you really just need NICU and neonatology care kind of thing. So there's no guidelines. It depends purely on the person who's offering the fellowship, but you should just basically during your interview have a clear expectation. What are you being trained for? What is the expected number of cases you're gonna get in your first or second year? And what is their vision of how much like independency you're gonna have? And NAFNET did a survey a few years ago. NAFNET is the North American Fetal Network. All the fetal surgery centers are part of that network. They did a survey a few years ago and they found the people who finished the fellowship and they went into careers, they felt very comfortable doing laser procedures and like other smaller procedures such as coagulation and RFA and intrauterine transfusion. But many of them did not feel independent to do, for example, fetal or spina bifida repair, just because of the nature of these cases are less and the main surgeon might be the main person who's doing them kind of thing. So just FYI.
Yeah, so it sounds like it's a true like master and apprentice model that you got to figure out which master you want to work with. I'm thankful for mentioning the NAFNET. So when we see that acronym, we know that that's what it's applying to with fetal interventions. Let's circle back because some of the audience may not know some of you mentioned treatments, but let's take a step back about conditions because this is a specialized version of what maternal fetal medicine does. So can you tell us like what conditions does a fetal interventionalist treat that maybe a maternal fetal medicine wouldn't?
So, and I also want to mention why do some people call it fetal therapist? Because it's not like the usually when you hear the name, you think it's surgery. It's not necessarily surgery. It's really any intervention that you think might improve outcome. And it could be simply medical therapy. So it's either surgical or medical therapies that aim to improve survival or reduce morbidity kind of thing. So if we come to the surgical portion, for example, the number of cases any place would kind of mention they're getting is complicated monochorionic twin procedures. So you have twins who share placenta, monochorionic twins, and they end up with certain complications because of those imbalanced share in the vascular connections. So most commonly is twin-twin transfusion, and the treatment is laser surgery, and that is done fetoscopically, so it's minimally invasive approach. Then you can use the laser for other rare condition in the twins, such as twin anemia polycythemia, such as really bad selective fetal growth restriction. You can do laser. For monochorionic twins, also sometimes you might do other things, not necessarily laser, such as selective reduction using bipolar, using radiofrequency ablation, using microwave thermal ablation. So this is like for complicated twins. For spina bifida, we mentioned fetal surgery for spina bifida. For congenital diaphragmatic hernia, we mentioned the tracheal balloon occlusion. For any type of fetal anemia, whether that is from hemolytic disease, whether that's from parvovirus or some genetic anemia condition, we do intrauterine transfusions. Then you have those conditions that you would require a shunt for. So for example, you have lower urinary tract obstruction or known as posterior urethral valve. So we put a shunt into the bladder to bypass the blockage and drain the fluid into the amniotic fluid. You might have a pleural effusion, and then we put a shunt in the chest to drain the fluid to the amniotic fluid. So then you have a little bit more rare conditions, such as amniotic band. So you have those amnions that wrap around different limbs, and they might cause amputation. So depends on certain eligibility, we might offer resection for those bands. You have a placental chorioangiomas. If they result into like cardiac overload and poly, etc., we might offer laser or coils or just symptomatic intrauterine transfusion therapy kind of thing. So this is kind of like an overlay of surgical procedures, and there's like others that becomes like a little bit more and more rare. But when it comes to the medical portion, this is more of the innovative portion. So it's like those are therapies that you do after the baby's born, but you're thinking as a fetal therapist, what if I started when the mom is still pregnant? So for example, Tony, you might be aware about the patient we kind of did patient story on was cystic fibrosis, in which we started the Trikafta early when she was pregnant. And it's kind of like the thought is it might reduce the bowel complications from the CF if we kind of start the treatment early. So the mom takes the pill, it goes transplacental to the baby. There was recently a case report that's published in the New England Journal, and like our group is currently looking into possibly starting it as well, which is a pill medical therapy for spinal muscle atrophy, SMA. So that case report was published from St. Jude. And we as a group, we already had a meeting with our SMA team and considering of possibly if we found an eligible patient, it's maybe, again, there's a lot of unknowns, but it's one of the therapies that's proposed, for example. Other things such as sirolimus, which is an mTOR inhibitor that's been proposed out there for cardiac rhabdomyomas. Similarly, it's a pill mom take, goes transplacental to the baby. So, and so on and so on. So it's medical therapy, yet it's very innovative, not much research, not much data, but there are registries out there that people try to put those data on, and hopefully we have more clarity in a few years ahead kind of thing.
Yeah, this will be interesting to cut and splice all the things that you just mentioned, because you made it sound very simple, but there's a lot of moving parts that are in there. I think if someone is listening to this and maybe they're interested in general OBGYN, or maybe they're a maternal-fetal medicine thinking about next steps, let's use monochorionic twins as an example. You don't have to give specifics in terms of like how to actually make a referral, but what would you say is the limit of what a general OBGYN can do in terms of monitoring a monochorionic twin before they should refer to a maternal-fetal medicine, before they refer to a fetal interventionalist or fetal therapist?
So this is a very, very good question. And it's a very interesting question because it's very variable across states and institutions, who does what kind of thing. So for example, I think in our state, we say for any twin, then at least you can have the anatomy done by MFM, for example. In certain areas of different states, the generalist might do kind of like the whole spectrum of ultrasound. But it's very important for those pregnancies, for monochorionic twins, to start with is establish chorionicity. That's really the most important thing. And that's overall has been a general OBGYN task, because when patient gets pregnant, that's who they see. They're OB. They don't come to MFM. They don't really know they have twins. The OBs usually kind of diagnose that they have twins. And the best time to diagnose chorionicity is 6 to 9 weeks. So I love it when I go to someone's chart and I find early scans and very nicely displayed the inner twin membrane that looks very clear, well documented that this is monochorionic twins, because it's very clearly it's monochorionic twins. And the problem is once they get into the late first trimester, second trimester, using that guide, the inner twin membrane becomes less beneficial because they're gonna start looking alike, and you can't really say is it monochorionic, dichorionic, especially if they are same-sex babies and placenta looks kind of one place. So I would say any generalist out there who's hearing this podcast, focus on the importance of 6 to 9 week ultrasound, 6 to 9 week in determining chorionicity.
Could you also comment about labeling A and B?
Yes. So labeling is also challenging, I have to say. Finding the inner twin membrane, labeling. So we do have like kind of different guidelines for labeling, but I would say if you label 1A and 1B, be a little bit specific of which one you decided to call A, which one you decided to call B. Yes, as they grow, they might change and shift, etc. But add a little bit more description. For example, say on maternal right upper side, I decided this is A. On maternal left lower side, I decided this is B. I think it adds a lot of value. We might end up changing the labeling as MFM when patients come to us, but it really helps when you start a kind of a scheme and then people kind of look at it and follow it and understand what you are looking at. So that's very important. Like when you label A and B, just kind of add a description, which one you decided to call A, which one you decided to call B as a generalist. So yeah, the dating and labeling and determining chorionicity is really important for early first trimester. then the general rule of thumb, if you decide this is monochorionic twins, you should bring them back at 16-week. I can tell you in Europe, they started bringing them back at 14-week because they think you can even detect TTTS early, which is true. I mean, we detected TTTS at 14-week. The problem is you cannot offer laser surgery less than 16-week, right? Anything less than 16-week, it falls under research kind of thing. But generally, the SMFM or ACOG have say, start following them at 16-week, every 2 week, and then until basically they deliver. For uncomplicated monochorionic twins, we deliver them by 37 weeks. So that's kind of the general rule of thumb. But then anything that looks concerning to you, never hesitate to send to MFM. The fluid looks discordant. One fluid looks a little bit high. One fluid looks a little bit low. One baby appeared smaller. Something looks off. Never hesitate to just give a call to your nice MFM friend and say, I have this patient. What do you think? Because I think they will always say and be happy. Send her. We'll look at her and see what's going on. We'll send her back to you. So yeah, kind of this is the general rule of general OBGYN.
So now, for that maternal fetal medicine, staying with the monochorionic example, when should they be referring to you in terms of stages? If we're following the Quintero criteria, when do you want to be involved?
I want to be involved, honestly, and it varies between fetal therapist and who's the person referring, right? And how much they have of a strong ultrasound unit. So after working a few years, I kind of know how good that ultrasound unit. Are they like radiologist ultrasound? Are they specialized MFM sonographers kind of thing? So that's how it affects my decision. But generally, if an MFM calls me, I mean, I know that they have a good, highly specialized MFM versus if a generalist who relies on radiology sonographers kind of thing. So usually I would like to be involved at least in the pre-TTTS. Just look, scan one time. I agree. What is the pre-TTTS? Pre-TTTS is basically when we say something is cooking, is not yet TTTS. So you can have one baby that has low fluid, the other is normal, or one baby has high fluid, the other is normal. Or so this is kind of generally, there's a fluid discordance, but yet not poly-oly kind of thing. So we call it pre-TTS. I would love if I can see them for at least one time. Yes, make sure. The reason why I'm saying that, and again, so many people say, well, no, pre-TTS, just keep following and send her to me when she's TTS. Because I did have patients whom they thought to be pre-TTS. When they came to me, they were already like stage 2 and 3. So after having these encounters, I was like, no, send her to me. I'll see her one time and I'll send her back to you kind of thing. So I would say pre-TTS. If you have her stage 1 or anything higher, then definitely refer to the fetal interventionist, at least to kind of do the whole evaluation. What we do may be a little bit extra than other MFM centers. We do full Doppler evaluation, we do full echo evaluation, and some of these findings might affect decisions. So it's known that we do laser surgery for stage 2 and up, but there are certain things when it's a stage 1 that we might say, you know what, I'm going to offer therapy, such as if her cervix was very short and we think she might just labor and deliver, or she's very symptomatic from the severe poly. So those are things we might offer laser even at stage 1.
When I trained, we were doing amnio reductions for these TTTS cases, which temporizes things but doesn't get to the root of the problem. And then, the paper came out about using laser therapy. So pretend you're talking to a student that has not seen that video and knows what you do. Briefly take us, when you say laser therapy, what does it actually entail?
Yeah, so that is interesting about the amnio reduction. You're right, like that's what they did. And we can talk about it, like sometimes
I don't want to refer to my age, so...
I was about to tell you, were you a resident?
We're not going back that far, yeah.
Yeah, that's cool. No, I'm not going to ask you about your age, although you just celebrated your birthday.
I am on social media, so that is public domain.
You're on social media. Your age is all on social media.
Yes, yeah.
So,
all right, keep going, laser, yes.
Yes, let's go back to laser. So basically, we call it fetoscopic laser coagulation. So kind of that's the name. We use fetoscopy, which are instruments just like laparoscopy. When it comes to the fetal procedures, those entry points that you do, whatever entry point you make using your needle or instrument, it was found by animal studies and in vitro studies, they don't heal. The amniotic membrane don't have a healing capacity. So we always aim in using smaller and smaller instruments. So although it looks like laparoscopy is not as big. So the biggest fetoscopic may be like 4 millimeter kind of thing, okay? And we use different entry technique. We call it percutaneous. Percutaneous meaning the skin to uterus to inside the uterus. So it's like one entry through the skin all the way into the amniotic sac, okay? So that's what percutaneous means. And as I said, different sizes, it depends on different things, but generally 4 millimeter is the biggest size, okay? So through that scope, there's a channel there's like different channels. One of them you can add amniotic fluid or draw amniotic fluid, and there's a special channel for like a laser fiber, which is a very thin laser fiber kind of thing that you can pass it through that special channel in your fetoscope, and you go, and it's a very small camera. People think like we can have like a very nice panoramic view. Can you take a picture for the whole baby? No, I can't take a picture for the whole baby. It's like a very small pointy camera. Like the most place you can see is actually what you're literally looking at kind of thing. It doesn't give you panoramic view. We use 0 and 30 degree, but even with 30 degree, you can't really have much of a view. So we try to kind of, before going in, very, very important is we know what we call equator. Equator is that line. It could be like riggedy line. It could be kind of, it's not a straight line. It's just a line, curved, whatever it is, of those vascular connections between both twins. So you have to have a good understanding where your equator would be to end up being 90 degree against your equator. Otherwise, you cannot just go in, oh, this is not a nice spot. Let me go out and go another entry. That's not good because she's gonna just deliver and break her water. Have a preterm, preterm. So the entry point you decide on should be it. And you should have very good idea of where to enter. And that is generally should be almost 90 degree against your equator, which is that line in which the connections would be. That line is determined by where is the placental cord insertion of each twin. So if you have one cord insertion here, one cord insertion here, left and right, the equator would be the line between two cord insertions kind of thing. So if you know the line, you look at the mom's abdomen. We always go into the sac that has polyhydramnios, so that's the recipient sac. We don't go to the sac that doesn't have a fluid. So we end up into the recipient sac, 90 degree against the equator, and we try kind of find these vessels, pass the laser fiber, burn them. And then the trial that came, which is the Solomon, basically they found that if you burn in between your burning points, so we call it dichorionization, meaning you create two placentas kind of thing. They found that it reduces recurrent TTTS and TAPS after the laser, because TAPS, you can have those very hair-thin vessels that you can't actually see them really well. So that's why we burn in between our burning points, what's called Solomonization kind of thing. So that's kind of in brief what we aim to do during laser surgeries.
Yeah, thanks for sharing that. And what I think is cool with our medical students that are on the rotations, sometimes they don't get to catch a baby right away, but they do always get to capture a placenta. And so showing them the anatomy, you can see like why it's still relevant as you've gone through training through medical school, residency, fellowship, and fetal therapy. You're needing to rely on that anatomy. So there is value in delivering a placenta.
A lot of value, especially monochorionic placentas would be very cool.
Yeah, I wanted to go back to one other therapy that you just mentioned, which was in utero spina bifida repair. You mentioned some of the other places earlier that, prior to having like a fetal interventionist here, we would send, people out, which is not just a burden from a medical standpoint, but it's also, a huge burden for families if they have to travel and stay in certain places. So it's great that there are more places around the country that are able to do this. Can you just talk about like what that was like, who you worked with to do that in utero therapy for that?
Yeah, that's a very good point you're bringing, Tony. It's like the burden. Many of these places do require some of these pregnancies to stay nearby the hospital. It depends on how smooth or what type of technique they do. So that's a big commitment from families to travel across states and be far away from their families. Insurance companies might not pay. Some of them end up paying out of pocket. And aside from the anxiety that comes from having a baby with a spina bifida. So I think for our institution, the reason why our institution just feels so much pride about us offering spina bifida and their huge support for this program, because they acknowledge how important it is for our families just to offer everything in one place and be near to their homes. So spina bifida, for those people who don't know what it is, people use different names for it. Some people call it open neural tube defect. Some people call it spina bifida. People call it myelomeningocele if it has a sac. If it doesn't has a covering sac, call it myeloschisis. But basically, it's a defect that resulted into kind of like bulging of the spinal cord nerves through that defect, which could be along anywhere through the spinal cord kind of thing. And until like 2010, before that, people used to do like the repair after birth, baby's born, usually the first day or so, babies will get the repair. And then the famously known MOMS trial came in 2012, in which they found that if you do prenatal repair, you can reduce the need for like babies needing the shunt, and you can improve the movement for those kiddos. So that's why it became a standard of care that if we diagnose a spina bifida, is we mention fetal surgery as one of the options. Is not anymore mentioned as like a research option. It's standard of care to mention it as a standard of care option. So different institutions do it in different ways. And for example, the way I was trained, we call it laparotomy assisted fetoscopy. What I do now, it's mini laparotomy assisted fetoscopy, and I'll explain those terminologies. And some places do open repair. So what it means is the variations is how do you open the skin and how do you open the uterus? Okay, the MOMS trial, they opened the skin, big incision, like either up and down or C-section like cut. Then they opened the uterus 6 to 8 centimeter cut. So that's open repair. And then to improve maternal outcomes, the fetoscopic approach came. And most institutions, the way they do it is they call it laparotomy. So they still open the abdomen up and down or like a big C-section cut. And then they put the scopes through the uterus directly. While the approach that we offer in our institution, like Tony, is what we call a mini laparotomy. So basically, instead of making a big skin incision, we make a 3 centimeter incision into mom's skin. And through that small incision, we put our scopes. And that showed like huge reduce in maternal recovery and complications. Moms can have vaginal birth. They leave home on day 2 and 3. They ambulate literally the second day. No pulmonary edemas, no dehiscence or urinary rupture that were reported in the open repair, while maintaining the fetal outcomes. So similar, like the fetal outcomes are the same as the open repair, but improving maternal outcomes. So these are kind of the different approaches. In Brazil, and I think in some places in Europe, they do what's called percutaneous. So don't make any skin incision in mom, but just put your instruments directly through the skin. They had very high PPROM and preterm birth. So this is not an approach we decided is good for us, at least as of this point. If we can improve the instruments we're using, maybe. But as of now, we're doing the mini laparotomy fetoscopy.
Thanks for describing that. That's very helpful for some of us that have only read about it. So very cool. I'm going to transition and ask you about some of your recent research, but I was curious about these procedures and like volume and maintaining skills. So you do a lot of fetal blood transfusions. And then I know, just because I know you, the lasers come up. And then fortunately, some of these other interventionalists, because they're more rare, they don't happen quite as often. So how do you stay sharp with all of these things? And do you think that there is a magic number that people need to do to stay up to date with their skills?
Yeah, that's a very interesting question. And I think it varies a lot by the person, like themselves. And just like, when we get a new resident, if you have 4 residents, you have one resident who can do like sections and quicker than her co-residents, for example, or his co-residents. It just varies by person, how fast they pick their skills, how good they maintain them, and how much they need to maintain them. For lasers, I think that research or survey that NAFNA did, I think it said 12 to 15 per year for laser procedures. For MMC, I don't think there is any data out there, honestly. I mean, in our institution, I mean, as of now, this is like a new approach we've offered for a few months now. So it's been like once every 2 weeks, I would say once every 3 weeks. But regardless, it's not only my skills that I worry about in complete honesty, it's the team. So you need your nursing team, you need your anesthesia team. Like it's a whole teamwork, right? And you need your fellow to help you in certain things as well. So no matter how confident I am in myself, I want to make sure my team still know the plan and still remember the plan. And we have a lot of techs, a lot of nurses, and they might circulate it through cases. So for our particular institution, the way we do it, before a case, we do a virtual walkthrough, okay, in which we have the nursing, the anesthesiologist just join a virtual call for like 30 minutes and just go over the checklist and protocol. And we decided to do this at least for the first few years, just to make sure that if your nurse changed or if your scrub tech changed, or whatever debrief, we do debriefing after every case, and sometimes we change our protocols based on that debriefing. We just want to make sure everyone is still on track and up to date with how we do these procedures, what is needed from each team member during these procedures. And I think it just takes a lot of the pressure from your team by, oh yeah, we talked about it, I feel good, I feel confident, I know how the scrub tech, I know how to set my tables the way you guys want, the nurse, I know what you want me to document. They have a sheet, they document multiple points in the OR. I know what to document. So it's not only the surgeon, I think it's the whole team in complete honesty.
I love that. And, I think back to my training when there's so many different people, even on the day of the procedures, like how important it is to do that timeout and have everyone introduce themselves and what their roles are before you do something as complicated as that. That's fantastic. All right, I'm going to transition to your research, and I want to do this as more like the elevator pitch. I like the term TLDR, too long, didn't read. We're going to keep this like just what is the summary point? I've picked 4 of your recent articles. Before I get to the specifics of those articles, many of them employ something called a Delphi consensus technique that's on there. And as we're reading literature, that word, we see it, we may not necessarily know what that is. Can you briefly tell us what is a Delphi procedure and how have you used it in your research?
Yeah. Thank you so much. That's a great question. Me and Tony just published a joint Delphi together. So I'm delighted to talk about Delphi. So basically, there are certain things in medicine in which, I mean, you can do studies and answer certain questions, but there remains to be a lot of gaps in the literature that, given the rarity of that condition or the complexity of what's happening, is so hard to do such a good study and kind of come up with a solution of what should I do. So Delphi, it's a multidisciplinary consensus of experts in the field that usually involves multiple rounds. So it might look like a survey, but is not really just a regular survey. It depends on Likert scoring. So usually there is a minimum of 3 rounds of questions. You have to have experts of the field. So example, the one me and Tony published is preterm birth in twins, whether they have twin-twin transfusion or they don't have a twin-twin transfusion. And we touched a bit on multiple things like cerclage and what type of cerclage and when do you do cerclage and progesterone and pessary and all these questions that really the literature might fail to answer them kind of thing over the years. So you start with your first round and you identify your experts, and there are certain ways of identifying the expert, whether through organization or publication records, etc. And then once you identify your expert, that's called the working group, you identify your core group, which is like the main author group kind of thing. And then you start building your questions into most commonly as a Likert scale. And based on the answers, you decide, for example, if you have more than 70% agreement on certain point, this passes. If it's 60 to 70, they have to go to the second round. If it's less than this, then they fall off kind of thing. So that's how you go through rounds, and then sometimes it goes more than 3 rounds, sometimes it stops at 3 rounds. It depends on when you can reach consensus and what the points you can reach consensus on. So the Delphi, honestly, it's a great research methodology into those very rare things. Like the Delphi we did on hemolytic disease of fetus and newborn. We touched base on titers. We touched base on how to do intraperitoneal transfusion, which you cannot find any guidance out there in the literature. We touched base, okay, you do an intrauterine transfusion. How do you follow those kiddos? Multiple questions that relies on people, that's how they do it, or what's written on UpToDate, or what's written into the book kind of thing. But this is more of an multidisciplinary expert consensus of at least 100 to 150 experts kind of thing in each Delphi.
I'm glad you mentioned UpToDate. We're at a time with transition and probably the focus of a different podcast about medical education, but like UpToDate, it's written by an author. They've looked at the literature and come up with recommendations. A Delphi technique is a way to really quantify expert opinions from a large audience for that, which is great. Now, you mentioned one of these studies, so this is my little TLDR part. I'm going to mention one of your publications from this past year, and why don't you just give me, you have to restrict yourself to like 2 key points that you learned from this. Okay, so I'll tell you the study, and you tell me what are the 2 key takeaways. I'm too busy to even read the abstract. I'm just going to take it right from your mouth. All right,
Okay.
So let's start with the first one you mentioned, monitoring and management of hemolytic disease of the fetus and newborn based on international expert Delphi consensus. What are 2 key takeaways?
The 2 key takeaways are we identified which group might benefit from early medical therapy using, currently it's IVIG, although there are studies currently looking at nipocalimab, so I'm not going to talk about that. But IVIG, we identified which group you can offer IVIG, and we identified the dosing and how do you give IVIG for that group. So that's really important. And then the other important key point is we identified multiple unknown aspects about the intrauterine transfusion and intraperitoneal transfusion, so intravascular or intraperitoneal transfusion, including technique, how much you give, and how do you follow it. So again, not precise key point.
No, but those are good. I'm interested now to go search it. All right, the next one. Decreasing trend of gastroschisis prevalence in the United States from 2014 to 2022.
Yes, we did find that there has been decrease in the high-risk group that has been known to be associated with gastroschisis. So, for example, we found less use of cigarette smoking, less numbers of young primigravida over the years, and we attributed that to the reduce of numbers of gastroschisis over the years.
That's great. We recently had Dr. Jennifer Twangy, who wrote this book called Generations about different societal norms across generations. And she showed a picture of like what high school students look like in the 70s. And I'm pretty sure he had like a bottle of whiskey and a cigarette. He looked like a 40-year-old man. And then she said like the trends today, people are doing less risky behavior, less smoking, not having sex as early, not as much alcohol. And it's interesting that we hear that. And this is potentially one of, a good consequence of that, lower complication rates of something that we associate with these risk factors. All right, 2 more studies. The next one, fetal lower urinary tract obstruction, Delphi consensus. What is a couple key takeaways from that?
Okay, oh my God, that's like also a lot of things that we identified. So we identified the ultrasound markers of poor prognosis in which the offering shown might not be helpful. And that is usually cortical cysts and poor filling of the bladder after the first bladder tap. So that's kind of important. And we also identified so that Delphi included something called Core of Outcome Set, COS. So this is also now a lot of journals and researchers push people to use Core of Outcome Set. Core of Outcome Set is when you want to look at something outcome, you have to generate first a consensus of what kind of outcomes I should look for in this population before you actually start looking at those outcomes. So This Delphi also included core of outcome set and included patient population, which is not easy to do. So we got actually patients, which are like either patients themselves or parents of patients with posterior urethral valve. And we asked them, what do you think is very important outcome that researchers should look at in this population? So this is what's called core outcome set. And we identified core of outcomes that if you want to do a study about luto, you should include those as part of your outcomes.
Fantastic. And the last one, I think you'd mentioned, this was another international Delphi consensus, and it's prevention of preterm birth and twin pregnancy. What's a couple key takeaways from that?
So I do want to say I'm a fetal interventionist, but I have a huge interest in multiple gestation and particularly twin gestation. Many of my research focused on twins. So in this Delphi, we looked at whether it's complicated, the monochronic twins, or just twins in general. Key takeaway points, again, a lot, but we identified certain procedural things that people keep asking. Like I see people keep asking about what kind of suture I use for my McDonald, or what kind of thing I can do to reduce rupture when I do my cerclage. So we identified those aspects when it comes to cerclage placement themselves. And let me talk about twin transfusion. We identified aspects of when to offer cerclage for these pregnancies. So for short cervical length, for cervical dilation, and when to do the cerclage in relationship to the laser itself. Like, do I do it before doing laser, during the laser procedure, or after the laser, and which one to do cerclage for? We identified those points as well.
That's fantastic. Well, thank you for summarizing what I'm sure was a lot of work. We went through our department's like research portfolio over, and just seeing your name on there was just so cool. I know how much work you put into this, and it's very impressive. So congrats. I just have a couple last questions while we wrap this up. You've described a lot of really innovative things that we can do now that did not exist 10, 20 years ago. What do you see in like the immediate future for fetal therapists? Any new cases that are on the horizon, new type of interventions that you can be using? What do you think's coming?
I really hope we get more minimally invasive as we go through the years. And that's like, you hear those, like you read about these cases, and you might even see videos of cases where people did, like, for example, big open exits for certain tumors or certain things. You see those cases are becoming almost none and non-existent and super rare now. Because as a fetal interventionist, we realize the importance of becoming more and more minimally invasive. If I can do a procedure with just a needle, that's great. If I can do it with like certain medication, that's even better. So some of the therapies out there that is currently under research, but I think it might become a thing, is prenatal intervention for hydrocephalus. So there have been a lot of research done into looking at long-term outcomes for babies with obstructive hydrocephalus, which is frequently due to aqueductal stenosis, and they have poor neurodevelopmental outcomes. So the idea is if you relieve that pressure on the cortex early enough in pregnancy, you might improve those outcomes. So this is out there strongly, and people are trying to get it into clinical practice. It's still in animal research. And another thing is still in animal research, but I would say that's more of South America, not other places, is they've been trying to look at encephaloceles. They found that if they manage certain of them prenatally, they're reducing the chances of microcephaly and long-term neurodevelopmental impairment. But that's just in the Latin America few centers they looked at it. And there's, as I mentioned, medical therapy. There's a lot of research currently done on gene therapy and stem cell therapy and medical therapy for multiple conditions. The researcher in UCSF is looking at, for example, mucopolysaccharidosis and those treatments that you can do prenatally, so gene and stem cell therapy, stuff like that. So this is all still under research, but every now and then you hear one clinical case coming out as case report kind of thing.
Very cool. My last question for you. I crowdsourced this from our fellows when I mentioned that I was going to get a chance to talk to you on the podcast. I won't tell you who asked it, but they want to know, Dr. Mustafa, How do you juggle all these things?
Oh God.
They
Who
have a
asked
great
that?
deal of I'm not telling you. They have a great deal of respect for you in clinic and certainly the fetal interventions and research, and they're just in awe of your productivity. So how do you juggle it? What advice do you have?
I love our fellows. I have to say a lot is thanks to them. They're just an amazing group of fellows, and Dr. Shanks, you did an amazing job of setting them to fellowship and getting them to be our fellows. They are a huge part of fetal intervention and ultrasound clinic. I rely a lot on them on like getting the patient to the OR, assisting in the OR, and making sure she gets proper follow up and management afterwards. I wouldn't be able to do it at all without them. They're also involved in our placenta accreta cases, which is another topic for another day. But thanks to them, I've been able to kind of like finish my day doing interventions and seeing a clinic. And when it comes to research, a lot of people do ask me that. So I'm like hired as mainly clinical, and I don't necessarily have allocated research time. So I do my research. If I don't have a case, I sit and finish my work or after work or etc. I tell people research is what keeps my heart pumping. It's just I love research, and it helps me understand what I do for my patients better and helps me become a better practitioner. So it's the fun part of what I do, and this is just personally for me. It might be different for other people. It's if you tell me what is fun about what you do, I would tell you research is a big part of it. Being able to learn and show something and show new evidence. So for me, it's never work. It's a fun thing that I look at it. I do have a family, and thankfully I have a very supportive husband. Throughout the years, I dragged him through states for different kind of fellowships, but he's also a huge part of keeping me grounded and sane and help me take care of 3 kids. So
I'm glad you brought up the family too, because we talk about work-life balance, work-life integration, and I think you do an excellent job with that. So.
thank you. You're so sweet. I mean, look who's talking. Someone with kids and
It's not about me.
managing the education and fellowship director and like.
It's not about me. It's all you, Dr. Mustafa. Well, thank you for your time and thank you for your expertise.
Appreciate you. You've been an amazing host, keeping it fun and cool. Appreciate you.
Do you have any last minute questions and things as we wrap up here?
No, I think I just want to say out there for those people who are interested, don't feel disappointed given the low number of fellowships offered out there. And if you don't get into one of them, just like keep doing what you're doing. If you decide to go for MFM job or you want to do fetal intervention later on, just like do best at what you do at that certain time of your life. If you decided to do MFM as a job and then later on you focus on your job and have fun at it and enjoy it and then embark on something else in the future if you want to. And always feel free to reach out to people. I can tell you, although it's only few of us out there who do this kind of career, they're all an amazing human beings and amazing educators. Don't feel like intimidated by reaching out to them and me or anyone. We're always happy to kind of hold people's hand and help guide them through this route, which might take an extra few years if you're willing to do it. But for me personally, been there, and I think it's totally worth doing it.
Awesome. Well, thank you for your time and your expertise.
Thank you.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.